I wanted to present about the evolution of the interaction between anxiety, irritability, and major depressive disorder. So I am Maurice Ohayon. I am the chairman today of the Symposium, and I am the director at Stanford of the Sleep Epidemiology Research Center. I have served as my disclosure as consultant in the past 3 years for Takeda Pharmaceutical, Jazz Pharmaceutical, Avadel, and Tris Pharma, and I have received educational grant from Novartis and Takeda. So my objective today are to quantify the importance of the association between anxiety, irritability, and depression in the general population. And more importantly, to examine the natural evolution of this triple association. What it means is that I am presenting a study that is a longitudinal study. So the population that was studied is a representative sample of the adult general population of USA. A total of 12,218 subjects were interviewed during the first wave, so during the years of 2002 to 2011, and 10,931 at follow-up from 2006 to 2015. This, I must say some word about why from 2,218 to 10,931 is the number of subjects that we lost. All of that to tell you that this is a true longitudinal study where the subject of wave 1 corresponds strictly to the subject of wave 2. It's not a comparison between agglomerated data at wave 1 and after at wave 2. So about 3 years elapsed between the first and second interview. Why? Is because I wanted to keep in mind what we do in medicine, that is longitudinal study have normally lapse time of minimally 3 to 5 years, like in all the medical field. Things that we don't respect, in fact, in psychiatry, but that is an error. We must have exactly the same standard that the other specialty of medicine. So we were using an instrument that is the Stanford EVAL system that I have developed myself. That is an artificial intelligence system that was first designed in 1986. So it's an old system, but that is every time going ahead. Presently, it's a neural network, and this neural network is based on the upfield neurons that use fuzzy logic for the mathematical side, and a knowledge base that it comprises a standard questionnaire and diagnostic pathway covering the DSM-4, the DSM-5, and the international classification of sleep disorders. Since this was extended and the ICD-10 and 11 were added as a knowledge base. He formulates, so he's working practically like a clinician, but don't be mistaken on this side. He's still a computer. He has not the intelligence of a clinician. Far from there. He is formulating a diagnostic hypothesis that it attempts to confirm or to reject, and concurrent diagnoses are allowed in accordance with the DSM and ICSD, but also the ICD. Terminates the interview when all diagnostic possibilities are exhausted. What it means is that he's doing positive diagnosis and differential diagnosis. And that is what is often missing, often all the time missing, also in the data claim. So in the data claim, you have a positive diagnosis. You don't know what was eliminated, on what it was eliminated. You have no idea of what happened there. Here, we have all the facts that are permitted to the system to conclude to a diagnosis, for example, of MDD. So I will pass on the instrument per se is a neural network expert system that is very well known in the mathematical world and in computer sciences, because it was one of the first that was using the deep learning many years before ChatGPT. And the difference with ChatGPT, because now is becoming the norm because of the success of ChatGPT. ChatGPT is a neural network specialized in dialogue, but incapable to do any kind of diagnosis. And AdInfer is specialized in diagnosis, positive and differential. So what is the definition that we were using for this study? So major depressive disorder, all DSM-5 criteria needed to be satisfied. Anxiety symptoms present for more than 3 days per week, minimally, feeling anxious or nervous, excessive worries, fears that something terrible might happen, difficulty to relax. Irritability, the symptoms must have perdured for more of 3 days per week, easily annoyed, irritable, temper outbursts for no apparent reason. So the fact, and that with the prevalence is without any discussion, and again, we didn't select our general population sample on this element, but you have here the prevalence for each of the elements that we are interested. First, 5.1% of the total sample of wave 1 had 1 month's prevalence of MDD. We can be very precise. And you see 5.1%. Significant anxiety was observed in 63.1% of subjects with MDD. More women than men with MDD reported anxiety symptoms. Irritability was observed in 46.9% of subjects with MDD. More men than women with MDD reported irritability symptoms. I attract your attention on this: more men than women were irritable. Keep that in mind, because you will see what is happening to these people that are irritable in terms of medical care. You will see that the men, and we know it as a physician or as psychologist, that men are going to see a physician with reluctance, more than the women that have a regular consultation with a GP, for example. Anxiety and irritability occurring concomitantly were observed in 32% of subjects with MDD, 1/3. You don't find this number remarkable. 32% of all the people with MDD with anxiety and irritability. So now the question is, do we have a difference for the MDD prevalence by age group? And what is happening for the anxiety and irritability inside of this prevalence of MDD by age group? So here I put you, for example, for 18 to 24 with anxiety and without anxiety in gray, so in red with anxiety. And you see that inside of the prevalence of MDD 18 to 24, that is 6%. 6% of the people of 18 to 24 have an MDD. Inside of the 6%, 76.1% are with anxiety. Without anxiety, the rest, so it's practically 24%. You have the same for 25 to 34. You see, the proportion is exactly the same, practically, by age. Now, when you look at irritability, here it's pretty interesting. You have, again, for 18 to 24, a prevalence of MDD of 6%. And inside, you see that half of them have irritability. And you see that the proportion is very important between 25 and 34%, 34 years. You see also for 35, 44, where it's important. So irritability, I would say between 25 and 44 is pretty high inside of MDD. It is diminishing with age to be the lower over 65. But the best question that we can have on this side is how the things are going at follow-up at wave 2. So remember, at wave 2, we have lost practically 1,800 subjects, and we are no more than at 10,931. That is, on a period of 3 to 5 years, not a big loss of people. I can tell you the people were insisting for some of them to continue to be part of the study. So here I put the MDD status at follow-up, and at follow-up, the MDD status can be a full episode, a partial remission, a complete remission, or having only some depressive symptoms. Okay? So if I take with this repartition and I look at the symptoms that I am interested, having no anxiety but irritability, we have in the full episode 2.9, partial remission 7, complete remission 1.9, depressive symptom only. But what is the most interesting is anxiety symptom alone, and here you see, and in bold, you have the significant difference. You have 5.9, 11.1 at partial remission, complete remission 11.6, and depressive symptom only 8.1. So you have always this anxiety symptom alone that are present. Now, irritability, 6.6% for the full episode. And I attract your attention on complete remission, irritability remain at 7.5%. And when I take the mix of anxiety and irritability, the number are becoming really very big, 15% in full episode, partial remission 19%, complete remission 20%. So you see here is telling us also if you have a complete remission, anxiety and irritability remain. So one of the questions that I have for all the people interested by treatment, Alain, Andrew, also, the question is, by any chance, our antidepressant treatment, they don't work on anxiety and irritability also in complete remission. They remain. These are the residual symptoms that are there. And they are not minimal. Anxiety and irritability is really present. So, as I put, nearly 5 times the relative risk of having an MDD. Sorry. So what is now the incidence of MDD? The beauty to have a longitudinal study is that you can look at the incidence defined as the lifetime first occurrence of MDD at follow-up. So at initial interview, the presence of irritability alone and irritability accompanied with anxiety symptoms increased by nearly 3 times the relative risk of developing a MDD for the first time at follow-up. So here we have the natural history of MDD, and you see that irritability with anxiety symptom and irritability alone are a big risk to develop an MDD. It's very important because some people were thinking that the symptom of depression at minima must be present before the MDD. It's not true. It's anxiety and irritability that are first there. And you will see, remember that one, anxiety, all the psychiatrists, also the GPs, they know that this is the bed for MDD. No problem. Irritability, also the psychiatrists are not knowing it. We didn't train the psychiatrists to know that irritability is one of the first symptoms of MDD. It's paradoxical. So here you have the number, and you see that incident MDD, so irritability alone, 5%. And you see that anxiety and irritability, 4.5. But you see that irritability has a central role. So for the recurrence of MDD, the presence of anxiety symptom alone and anxiety with irritability at initial interview predicted the recurrence of MDD at follow-up. The relative risk for relapsing into a full episode of MDD at follow-up was 4 times higher in participants with anxiety accompanied with irritability and nearly 2 times higher in those with anxiety alone. Again, is something totally new. We were sure knowing that anxiety was important for depression, but anxiety with irritability, no. And the number here are without any discussion. Is that a fact? Now, the way to interpret all of that can be discussed between us, but the number are the number here. You have anxiety symptom alone, you have 3.8. Anxiety and irritability, 8.4. Irritability alone, 2.8. No problem. Now the persistence of MDD. And here we were defining persistence as the presence of a full MDD at both initial interview and follow-up. And here, start to think very carefully. Relative risk of persistence were nearly 7 to 25 times higher with anxiety and or irritability when they were present at the initial interview. And you see this number, again, they are given with a good significativity. And you see that, again, anxiety 3.4, irritability alone 2.5, anxiety and irritability 6.9%. What is always very interesting is that irritability, nobody, I suppose, in the field of psychiatry was on it. Anxiety, yes. And anxiety and irritability, probably very few people were knowing. Does the presence of anxiety and or irritability impact treatment? So effectively, short answer is yes. When anxiety is present, more likely to be prescribed antidepressant and anxiolytic. But what is very interesting, when irritability is present, more likely they will receive an hypnotic. And that is, you have immediately question coming. Why irritability hypnotic? It's because the people are complaining that they cannot sleep at night. But in fact, they are depressed. So they will receive an hypnotic. Is that right? So now when we look at the fact by themselves, you see that anxiety symptom alone, antidepressant 63%. You see that anxiety 18.8. Irritability alone, you see the treatment antidepressant, anxiolytic, and hypnotic. You see that they receive essentially hypnotic, 6.7%. But what is very interesting is anxiety and irritability, 58.7% receive an antidepressant, and anxiolytic 19.9%, and then hypnotic 7.3%. So how likely now MDD individual will end up in a psychiatrist's office? That was very interesting because first, when I did myself the analysis and that we were looking at what was coming, I got a big surprise. But the same surprise was coming when I presented for the first time this data at the APA. And it's really surprising. No anxiety, no irritability, 28.2. Okay. If they have anxiety symptom, 51.5% are going in to see a psychiatrist. If they have irritability alone, 16.5. If they have both anxiety and irritability, 45. But you see that if you are irritable, you don't go to see a psychiatrist. Also, with all what we know now, that it's the beginning of a depression. These people will not be treated. Guess what? Is worse. When they have only irritability is where they are the most exposed to attempt of suicide. And that is a big problem because these people are not followed. There are very few of them are finishing in the psychiatrist's office. And on the top of that, what we can say is that essentially the men are concerned. Remember what we were saying. Irritability is mostly prevalent, more than for the women, with the men. Men have more irritability. They have also a tendency to do not go to see any kind of a physician. But on the top of that, they don't want to see a psychiatrist. So they stay without any treatment. And I tell you again, is the period of depression that is the most dangerous in terms of suicide. So in summary, the prevalence of MDD in the general population at 1 month is 5.1%. The yearly incidence of MDD is 1.1%. The recurrence of MDD is 2.4 on a 1 month period. The persistence of MDD is 1.3. So what I was calling the two musketeers, anxiety and irritability in MDD. So irritability drives increase in incidence of MDD. Anxiety and irritability increase recurrence and persistence of MDD up to 25-fold. Irritability decrease likelihood to visit a psychiatrist and to be treated with an antidepressant. But for sure, we wanted also to say that it's not only two. It was effectively a third symptom, that is the one of anhedonia. I have not I will not present the result on anhedonia, but only to give you an idea. If irritability is very interesting, you see anxiety symptoms, 63.1, very high. Irritability, 46.9%, pretty high. Anhedonia, 70%.1. This is really the next study that must be done with anhedonia and to look how anxiety and irritability are interacting with anhedonia. Thank you for your attention.